All right, everyone, welcome to another APTA Connecticut Journal Club. I'm Stephanie Wyrock. I'm the Vice President of APTA Connecticut. And we have been running this journal club now since basically the pandemic started. And today we are joined by Dr. Fromberg. He is an orthopedic surgeon at Yale, an assistant professor in orthopedics and rehabilitation at Yale School of Medicine, and he's also the director of the Cerebral Palsy Lifespan Program at Yale New Haven Hospital. And he's going to present an article called State of the Evidence, Traffic Lights 2019, Systematic Review of Interventions for Preventing and Treating Children with Cerebral Palsy. If you guys do have any questions during this, I'm going to field them through the chat, so make sure you type in your questions through the chat. We'll come around at the end, and we'll make sure that Dr. Fromberg hears from you, and then we'll open it up to a discussion so that if you have any specific questions or you want to discuss anything with Dr. Fromberg about this article or anything related to children with cerebral palsy, we'll definitely open it up. So I'm going to turn it over to Dr. Fromberg, and he'll tell you a little bit more about himself and start the journal club. So thanks for joining us, Dr. Fromberg.
Awesome. Thanks everyone for coming here on a Tuesday night. The weather's not so good. Yeah, so as you heard, I'm a CP guy over at Yale, direct a program that aims to go from early detection all the way through geriatrics. And it's been a lot of fun. I'd say the most fun part of it, as you can imagine, is that there's not much evidence to guide the treatment of adults with CP. But how can you even think about that when you look at what we're doing for kids and babies, and it's not even perfectly understood among practitioners regionally, in the community, and even academic centers. So one of the things to constantly do is kind of go back to thinking about what you're doing with people that you're treating and think to yourself, is this something that I should still be doing, or is this something that maybe has been shown to not be so effective? And that's pretty tricky to do. I mean, I'm lucky enough to be young enough in my career that, the things that I learned in training are probably still contemporary and pretty well accepted. But I can imagine, 30 years from now, when I'm some old dude running a CP programs at Yale, that the things that I was doing in training are probably going to be crazy. And so it's very important to constantly get your continuing education. But luckily, every once in a while, someone comes up with an idea like this article. And the article we're going to review tonight is a 2020 update of a previous article that really changed how I viewed the state of the evidence in CP. So let me just figure out how I can advance my slides. No relevant disclosures for this talk. This is our article. It's the State of the Evidence, Traffic Lights 2019. Systematic Review of Interventions for Preventing and Treating Children with CP. The lead author, Iona Novak, is based in Australia, but as you can see, it's a very wide-ranging group of authors here who all contributed to try to really update what everyone should know as far as interventions. So the goal here is that everybody should be better informed in their decision-making. Now, remember, this is really for interventions. It's not for general topics like, most of the people with CP are right-handed or like have brown hair. It's not things like that. It's more of what are things that we're doing and do they work and should we be doing them? Or also equally importantly, what doesn't work and we should stop doing it. So the original article was published in 2013. This article sort of updates that because there have been a tremendous amount of reviews and high-level evidence that were published since that time. And so this sort of combines the original work with the newer stuff to make a larger, let me mute that person. All right, to make a larger group of articles from which to base our evidence or base our recommendations. Now, obviously, this is like a really hard thing to do because, CP, cerebral palsy, it's a dirty term. It's not even a term that means anything. It's not a diagnosis. It's literally a syndrome. So there's a huge movement within the CP community now to stop calling it CP. Many people are pushing this other idea of calling it genetic neurodevelopmental disorder. So everyone sort of has this thought that there's a genetic underpinning to CP. Maybe it makes someone more susceptible to a perinatal insult to the brain or something like that. But either way, we're finding that there's a lot of secondary CP, meaning there's a primary genetic cause, and you know who all these kids are because you've treated them. Maybe they don't have frank spasticity, or they don't look quite like the typical CP kid. Most of those kids are actually genetic, or the other term we would use for that is idiopathic CP. We don't know why they have CP. They were born at 40 weeks or whatever. So I'm saying all this to tell you that it's a huge heterogeneous population. There's no agreement on who fits into what basket. So then to try to study that as a group can be very difficult. So most commonly we'll use GMFCS to break people up. We'll use regionality like diplegic, hemiplegic, or quadriplegic. Those are pretty common for us to say, or even, motor type like athetoid, spastic, hypotonic, dystonic, things like that. So we try to make little boxes where we can fit folks into, but it's not always quite so easy. So then if you're trying to extrapolate research that's been done on this broad heterogeneous group of very different ages in very different places, it can be very difficult. Nonetheless, Dr. Novak and group attempted to do this. So this article, basically, it was just, you search all these different databases for higher level studies, meaning systematic reviews and things like that. And then sort of down the line, RCTs that all pertain to children with CP. So this is only for children, which is where most of the evidence is. So everything was excluded if it didn't describe an intervention, like what I was saying before. If it's just the prevalence of cerebral palsy in Fairfield County, that would not be included, even though it's great to know. Also, if it was adults, because this is a childhood sort of development type evidence paper. If there was a low level of evidence, so really kind of a poor study, low numbers, or expert opinion type thing, that was generally excluded. Preventative measures that are sort of generic, the example given is good parenting, like, yeah, okay, we know you should be a good parent, but maybe a more specific intervention that a professional could do, or at least teach a parent or something like that, would be more appropriate. If it reviews the entire discipline, for example, like occupational therapy or going to physical therapy, does physical therapy help after surgery? Like that's just a very generic thing. So those were also excluded. And then any studies that were not through total peer review. So then they took all the papers they found and sort of deleted a bunch by their title if they didn't seem to work. And then they looked at the abstracts, they deleted some more, and then they had a bunch of other articles and they read them really in detail, and then decided to include about 247 articles, and that was in addition to the previous study. So really, if you think about it, in the last, 6-7 years, 247 high-level articles about cerebral palsy interventions have come out. I mean, to me, that's amazing when you consider that most CP research is not very well funded. So there's not a lot of like NIH funding for CP if you think about how many people have CP. Whereas if you look at something like Down syndrome, there's like tons of money for that going into research, and actually less people have that. Unless I'm incorrect, I could be incorrect, but that's my understanding. All right, so for every article, they did two things. The first was they gave it a grade rating, which judges by the quality of evidence. So obviously like a meta-analysis, very high level evidence, so that would get a rating of 4, whereas very low, it's like a expert opinion, that would be like a rating of 1. So they judge the quality, and then they judge the strength of recommendation for use. And this is a rating system, by the way, that the reader gives. And then, so in order to give a strength of recommendation, you have to weigh the benefits and the harms, but also how cost effective is it? So if, some very specific type of therapy, it has tremendous benefit and no harm, but it costs, $1 million a year, then is the bang worth the buck? And how likely are you to recommend that? One example would be like for spinal muscular atrophy, Spinraza, or nusinersen is the other word for it, is the drug that gets injected that literally keeps these kids alive and adults alive. But it costs like $1 million a year. So obviously it's cost effective because it keeps people alive. The benefits are tremendous. The harms are minimal, but that would be a strong recommendation for use. Health equity is really an implementation feasibility go along with each other. How likely is this to be reproduced in various environments? And how acceptable is it to consumers? The best example I can think of for acceptability to consumers is I had a patient come to me from Portugal whose dad was a carpenter, and the doctor told him that the child, who is quadriplegic, cerebral palsy, spastic type, told him that if he was in too much of a scissored position, then his hips might dislocate. So the dad created this thing that looked like a war torture device to strap his son down, and he just kept him in it like almost all the time and grew. It was actually pretty great, but that is not acceptable as a consumer. I'm pretty sure that kid didn't like it. So obviously you would not strongly recommend that. So the grade system gets to look at both those things. What's the quality of the evidence, and what's the strength of the recommendation? Then the second thing that they did for each article was the evidence alert system, which is the traffic light system. And this is the best thing ever, because when you're in your office and someone says, like, I want you to do this, you could just look at it and see where the strength of recommendation is. So green means go, right? Let's say, the classic example here would be hip surveillance. You take an x-ray based on GMFCS and risk for hip dislocation. And that is very well documented as an excellent intervention. So green, do that. It's a good thing to do. Red, ineffective based on the quality of evidence. Red means stop, don't do it. So there's not many things that are red, but the things that are red really should be followed. I mean, there's significant evidence that shows that you either shouldn't do it because it's dangerous, or it's going to do nothing. So don't waste time, don't waste money, and don't waste parent energy and effort. Now, yellow is where it gets tricky, and obviously you can imagine most things are yellow. That's where you have to be careful. Some of the interventions may be effective, but we don't know enough about their effects. The research hasn't been too great. Maybe there's conflicting evidence. So in this article, the way that Dr. Novak and her partners did it, or her co-authors did it, where they basically said it's a weak positive or a weak negative, like probably you should do it or probably you shouldn't do it. So then, with knowing those two things, created these bubble charts. So the larger the bubble, the better the evidence. For each individual item, it'll say what the intervention is and specifically the outcome measured. So for example, the intervention may be Botox injection, but the outcome measured may be for drooling, for sialorrhea. So it's great for that. But if it's for, hip dislocation, Botox might be okay. So the same intervention may have different spots on the grade rating based on the outcome you're actually measuring. So that's a good example for the differences within one thing. And then there's this worth it chart where there's a line where sort of say like, all right, this is where it's kind of worth it to do it or not. So if you're above it or below it, do it or don't do it. In red and green, it's kind of self-explanatory. So we'll dive right into this. I'm just telling you right now, like this, there's a lot of interventions on here. There's a lot of outcome measures. I tried to break it down in a way that was kind of sensical to me, but we could go anywhere with any of these things, and you could talk for hours. But what I'll say is, if you haven't looked at the article, I would definitely download it, and I'll plug it later, but you should definitely download the supplementary material. It's a 51 or 52 page document that has literally every study that they looked at, the grade rating, first of all, what the study found. So it's great for someone who might want to just get a quick breeze, like, you pull it up on your computer and just hit find and say like, I don't know, vitamin K. And then you can see the actual papers that have vitamin K in it, and then what the grade rating, what the paper showed, what they studied, what the grade rating is, and what the recommendation is. So I think it's very worth it to physically get the supplementary material, which can be found on the web. Okay. So the way I did this was I started off kind of like in chronologic order. So beginning with antenatal prevention, these are things that might not apply to us as physical therapists, but I think if you treat CP, you should have a good understanding of everything. And, you know, the reason why CP, so if you read some places, they say that the incidence of CP has gone down because of antenatal and perinatal intervention. So people are living with less intense or less severe versions of this overall syndrome. But also by the same token, you know, we're keeping babies alive that are born younger and younger. So CP hasn't really gone away for that matter. But we do know that some of the things that you do beforehand and some of the things you do after are very good and very effective. So here's some good examples, you know, antenatally, corticosteroids for neuroprotection, kid at risk, magnesium, you know, these are just things that are given pretty routinely, at least when I was, you know, involved in L&D as a med student. These are things that you see all the time, and they've been shown to work very nicely. But antenatal, you know, for example, phenobarbital, to give that to a mom to decrease intraventricular hemorrhage and maybe later brain injury, you know, that probably isn't worth it based on the evidence. So these are all very good. So, and then you can see also for the outcome measure specifically, you know, obviously if a mom has high blood pressure, like preeclampsia or something like that, and the goal is to decrease the blood pressure, it would make sense for antihypertensives to give those to decrease hypertension. You probably should do it. Maybe there's not a significant effect or something like that, or it wasn't always effective, but probably do it, probably worth it. So a nice idea of how the system works. Now, neonatal prevention is very interesting because you can see a million things along the worth it line. So that just tells me that there's a ton of work to be done. You know, there's a lot of research here that needs to be done. Clearly, you know, a lot of kids whose mothers have herpes virus infections, they all get acyclovir. Why this one is not higher up is crazy to me. You know, you'd think like, all right, kids being born in a birth canal with active herpes infection, you should probably give them an anti-herpes virus medication. But I guess that, you know, the research hasn't panned out perfectly. I mean, there's tons of things that surprise me. Prevention of jaundice with phototherapy. Those are those blue lights. You think you see that all the time. But the thing that I think is most interesting about this chart is the hypothermia. So hypothermia as an intervention for 3 separate outcome measures. One for treating, you know, a hypo, or I should say low oxygen state, asphyxia is what they say here. For preventing cortical visual impairment. Sorry, it's two outcome measures. So for those two over 3 lines, which are directly related to brain injury, hypothermia is unbelievably effective. And you know, most hospitals nowadays do it, and it's really great to decrease for preventing severity of CP. Caffeine for extubation, very interesting. I didn't know that because I'm not really in the NICU anymore. All right, so now getting to the brass tacks, sort of what we came here for. Early intervention is awesome. Some of my favorite therapists that I've met since coming to Connecticut have been like the early intervention therapists that'll, you know, send me random emails about kids I'm going to see. A lot of you also show up in the office, which is even cooler because my 10-minute visit with the kid really means nothing. But when you come and give me the whole shebang and what you think, that's much more helpful, or even like a letter. So even if I don't reach out to you to thank you personally, I mean, those are really great. And some therapists send letters along or fax them or whatever, and it's very helpful. But as you can see here, you know, I didn't even know you could do constraint therapy in a kid this young, which is bad because I should know that stuff, but this is how I learned it. Constraint-induced movement therapy, less than 2 years, improves hand function excellently. And the rating is pretty high on the worth it line. So one thing that's happened here is that I've changed and then also, by the way, the CIMT or bimanual therapy to increase hand function or to improve hand function in the older kids is also very effective. So I've kind of stepped up my constraint-induced therapy referrals. I guess the problem is that with COVID, those camps might not be functioning so well. So we've had to get creative with it. But that's definitely something worth doing. Things not worth doing, I never know how to pronounce it, but Voita, I think it's pronounced, which is reflex locomotion, I believe. That is below the worth it line on every chart. So I've only had one parent tell me that they were doing that. And, I don't know much about it. There's a lot of therapies here that I don't know a ton about that I've looked up and things like that. But for the most part, there's not much that you shouldn't be doing. Obviously, neurodevelopmental therapy in its original form is not that good. I don't know that people are still doing that around Connecticut. I could be wrong though, but that is also solidly below the worth it line and in the red on a couple of charts, as we'll see. But basically, all the early intervention methods that people are generally doing tend to help and are very good. So so props. All right. Here's a couple of things that, let me hide this thing I can't see. How do I hide the meeting controls? All right, so here's a couple of things that I think have a very large effect on quality of life. So sleep and pulmonary kind of go hand in hand in my mind. Doing anything for sleep is great, except for obviously hyperbaric oxygen, just not shown to help kids sleep better or not. There's your trusty old Voita, which actually helps with diaphragm inspiration. Maybe the way that the reflex goes, but for gross motor function, really not helpful. But for here, it is. Exercise being one of the best things you could do for pulmonary function, I think goes a long way, which is why trying to get exercise treatment plans or daily exercise is very important. Drooling was a huge push of the CP Academy a couple of years ago, really because sialorrhea is associated with pneumonias and death. So getting drooling under control is huge, and you don't see anything on this list that's not worth doing. So there's a lot of injections, medications, some behavioral interventions that can be done, oral sensory, and then mealtime. So the one thing that I found very interesting here that I'll point out is gastrostomy. So when I can't remember the study, but they asked parents what were the top interventions that changed their child's quality of life, and number one was gastrostomy. Number two is actually spine surgery, if I remember that correctly. But gastrostomy gets a yellow grade here, really because the kids, while they have some benefit, like most families will report that they get the G-tube and they gain some weight and they keep their food down, obviously, and they do great and they feel healthier. But it gets a yellow because it's actually still, they're still underweight kind of routinely. So getting them to normal weight for age doesn't seem to be achievable in every kid with gastrostomy as the intervention. Self-care, very important as we look at children becoming adolescents and adults. Lots of things you could do. I'm seeing, before COVID, I was seeing more and more animals in the office, which was a lot of fun, a lot of therapy dogs, and they sort of help folks get dressed and things like that. Even people who you would assume, maybe someone with diplegic CP whose arms are great and function at a very high level, still may lack some of the fine motor skills needed to do things like getting dressed or things like that. And for some reason, animals can totally assist with self-care and picking things up and things like that, and also socialization as well. Communication is great. I mean, it seems pretty silly, sorry about that, the intervention of literacy would help the outcome of literacy. But despite that, what it's showing you is that it works. You should, when you work with someone with cerebral palsy, you should assume that this is someone who can and wants to communicate. So you should at least refer, if you're not a speech language pathologist, you should make, or if you're an early intervention therapist, you should ensure that someone is getting the proper communication therapies that they need. And there are many out there, and especially in 2020, I mean, we have so much assistive technology that every type of interaction you can think of and every type of cognitive task can usually be replicated in some way or augmented with technology at this point. Like you can see under the cognition, you have assistive technology, so robotics. Robots help with cognition, and they also help with play. There's a whole bunch of stuff here. So now this is a good example here of yoga. There's a big push for some reason, like a lot of the teenage kids with CP are doing yoga. We're doing yoga in school, and so in their public schools. And so a lot of the parents were wondering, like, what's yoga helpful for if, quote, my kid can't stretch? Like a lot of them would say that. And so you can see here, there's benefits to yoga other than, making you the most limber person. But I would argue that they probably are more limber. We'll see where yoga is on the contracture page. Some of the stuff goes without saying, but yoga will do all these great things: attention, mindfulness. We'll see later some other things, but it will not improve executive function, which is interesting. And then what else did I want to say on this page? I think that's probably it. Parent outcomes, everything is worth it. Is a good thing to notice. Respite care, I always think, is very interesting to decrease stress. That goes a long way because a lot of these parents don't get a break. Respite care is pretty great. But some of these other things, I think it's worth seeing, like stepping stones, triple P. That stands for parent. Oh man, I looked it up like 2 weeks ago. But these are ways that you coach parents to improve their parenting, or different therapies that they can accept their child and on in this life that they have. So, I mean, we could talk for a solid 2 hours about parenting and things like that. But even just the everyday quality of life things like, dysphagia management and, educating your child. Now, pain is a little more tricky. As you can see, there's nothing green. And I think that speaks volumes for the most difficult part of my practice. So a lot of people think that cerebral palsy, as part of the natural history, pain is a long-term outcome, or pain is an expected thing that is seen, which is very disheartening to think about, for sure. But there are some things we can do. They're not the easiest things. So, massage, that's great. Animal assisted therapy proven for pain. I mean, that's been my go-to lately to kind of joke about. Yoga, not very good for pain. Although I have some patients that would argue with that, but by and large, not very well accepted. Deep brain stimulation is something that as a community, we're thinking about doing to help with pain as it relates to dystonia, but I think it just hasn't been able to been shown. I don't think anyone's been able to show that deep brain stimulation is good for the outcome of pain as well as it might be good for the outcome of dystonia, if that makes sense. Gabapentin is in the news with orthopedics because it's not proving to be as effective as people maybe have thought for perioperative pain, but certainly in CP, it's a little drowsy, but it is a psychoactive drug, so it can be kind of helpful. Botox for pain is very interesting because if it is pain that's rooted in your muscle tone, then it sort of makes sense. Certainly, if I see someone with a dislocated hip and that hip is very painful, sometimes the first thing I do, if medication, just over-the-counter medications don't help, my first intervention is usually just a Botox injection around the hip to decrease the joint reactive forces, and that seems to provide a pretty significant amount of relief. Things like radiofrequency dorsal root ganglion ablation, that seems a little aggressive, and it works. Sometimes I just haven't had any experience with that. Baclofen, again, is really the spasticity-related pain. Important to remember that spasticity itself is not painful. It's just the secondary pain that you can get from a tight muscle or a tight joint or a muscle spasm that actually is the painful part. One thing here, just know that, scoliosis surgery, pain, the only pain that I've ever seen us do scoliosis surgery for is when the ribs are on the pelvis. But even for that, I mean, you're not really doing the surgery to treat the pain. That's just a secondary thing. And then salvage hip surgery really doesn't get a perfect recommendation. So this is a hip that is basically dislocated and not reconstructible in its native form. So you're trying to salvage something out of the hip. No salvage hip surgery is perfect. The outcomes are generally not that good. I personally have gone away from all salvage hip surgery. I just try to do total hip replacements on folks with CP as young as they need to be. It seems to be a little bit better of an intervention, but again, you won't find it here because it hasn't been proven over time with high level evidence. All right, so this is the motor graph. There's a lot of stuff you can do. It's and it seems like every year there's just more and more things that people are doing for motor improvements. So I tried to break it down. So we go through the greens first. One thing that's super cool that I didn't know before is, well, I already mentioned constraint therapy being super awesome, but the umbilical cord blood is very interesting. So it gets a green recommendation, and this is for neonates. Like they have an event, you transfuse their umbilical cord blood, seems to be dose dependent. I don't know all that much about it. I'm not trying to tout it, but it seemed like the small numbers and low risk of giving a baby its own cord blood were made it very acceptable to get a green recommendation. Other than that, though, the interventions that you can do, things like treadmill training, mobility training, strength training is becoming more popular these days too, which is great. Partial body weight support treadmill training, that's the suspensions. I could be wrong. I don't think that's Alter G, which a lot of folks have experience with. I think that's the suspension systems. That could be wrong. A home program for hand function is very helpful. And then hippotherapy is huge in Connecticut. And I know you've all seen this. Kids have significantly better balance after doing hippotherapy. It's also awesome to watch too. Botox plus occupational therapy helps with goal achievement, which kind of makes sense because you're sort of, taking away the spasticity that's getting in the way. So a lot of good hand interventions. And then the yellow do-its. So these are the positive yellows, really pretty much everything. A couple of things that we'll talk about in a little bit are AFOs and simultaneous single event multi-level surgery, which is like a total body realignment. So I'll touch first on the single event multi-level surgery. With the outcomes of gross motor function, walking speed, and walking in general, it makes sense that if someone has really bad alignment, that giving them a realigning surgery should improve those things. But the gains aren't tremendous. It's not like you're going to go from being a GMFCS 5, spending most of your time using wheeled mobility, to a GMFCS 2 where you're independently ambulatory. It's not that kind of improvement. Otherwise, it would be the greenest green there is. It's really just more walking efficiency, and then some of the parameters that we see in the gait lab are improved. Botox, really great for hand function and muscle strength and things like that. We have new evidence that repeated Botox may actually destroy muscles, but no one really understands that yet. That was the theme. The theme of the CP Academy this past year was like hatred on Botox, but the evidence shows otherwise. So more to come on that in the next 5 years, I'm sure. Now, AFO is very interesting because the gains that AFOs will give kids in walking speed, gross motor, stride length, and basically gait kinematics are very noticeable. Now, whether they're permanent or whether they are a function of some other intervention is tough to see. Casting, also very good. So putting it for really lower extremity casting, just for gross motor and walking function. So really a lot of things that you can do, that I can do here, are very useful. Neural stem cells, we sort of, that's a positive recommendation as well. So there's a lot of interesting things here that I don't know much about. A lot of therapists may see intrathecal baclofen as a positive effect on gross motor and walking, and kind of laugh because you guys take care of the kids after they get the baclofen pumps. Sometimes when they get baclofen pumps, they become noodles and they can't do any of those things. So I think, the proper titration of the baclofen pump probably improves their gait parameters, removes their spasticity, and the kids who don't rely on spasticity for their ambulation will improve significantly. But basically, fitness, mobility, all these trainings, physical activity, these are all things that should be part of regular everyday life. Now, the things not to do. So these are the things that really don't work. Massage will not improve your gross motor function. Reflexology has no role in a disease. I shouldn't say disease. Reflexology has no role in a disorder that causes higher reflexes. So it never really made sense to me, but I'm not a practitioner of reflexology. So maybe that's, maybe I just don't understand. It's my own bias. The gross motor functions definitely do not improve with cranial osteopathy. That would be like craniosacral, has been long known. And so, I never recommend that. Hyperbaric oxygen for the younger kid, that will not improve gross motor, has not been shown to. And sensory integration as well for motor skills. All right, so muscle tone. So now we're starting to get into the things that I know a lot about. So the good things to do: Botox, really for spasticity, not for much else. I mean, Botox is an anti-spasticity medication. You don't give it for fixed contracture. Some people inject it all over the body, in the back, things like that. I think it's really great for the extremities. And then every once in a while, someone with dystonia, either in their neck or somewhere, that's generally pretty good as well. Baclofen's good. Selective dorsal rhizotomy seems scary, but it is an awesome intervention that doesn't decrease the need for surgery, but definitely decreases spasticity. I think just being selective, it's called selective dorsal rhizotomy because you're trying to select which dorsal rootlets from the spine you're doing, but I think of it more like you have to be more selective on who you're doing it on. And we have our own indications for that. Intrathecal baclofen, really great, obviously, for spasticity, and Valium, which is diazepam, is like, the post-operative medication of choice. What else did I want to say here? Hippotherapy is pretty good. And then there's a bunch of things that really don't help spasticity. So, you don't do single event multi-level surgery to decrease spasticity. You really do it for kinematics and things. Reflexology, we already talked about. Stretching is the other thing I want you to take away from this. So, stretching is not good. It doesn't work for kids with CP. We have to stop telling them that they have to stretch. It hurts. It's time consuming. It takes forever for the parents. Every more. It's all we got right now, by the way, in COVID. So it's kind of tricky. But assuming that we can get back to our normal world, telling a parent to stretch their child for 45 minutes every morning is probably not realistic, and also not going to be worth doing. There's not much of a benefit there. It's really more prolonged positioning and functional use that are going to push you over the line. Phenol, by the way, I use a lot of phenol during surgery, but I do know that Botox, so it gets a not worth it because Botox has a longer and better effect. So phenol can be scarring as well. So some people don't like it, but it has its role. Contraction alignment. Hip surveillance, number one thing you could do to prevent hip displacement. So if you are seeing a kid and they're 2 and they don't meet their gross motor, milestones, then that kid needs a hip x-ray. Even if they have low tone, most kids just need to have a surveying x-ray. Scoliosis surgery is good to correct scoliosis. Whether it's needed or the patient is correct for it is a totally different story. Botox plus casting is really good for passive range of motion. All casting tends to be pretty good, but giving Botox about a month before tends to improve the stretch that you get. Stretching itself and orthotics themselves are not worth doing if your goal is to just improve passive range of motion. They fall below the worth it line. Again, stretching is just not that great on its own. There are a lot of different orthopedic interventions you see here that all have probably worth it recommendations, but aren't green. Like hip surgery really is not green because not everybody gets a perfect result from it. And there's a lot of nuance there. I think the assistive technology, robotics, and things like that are going to really take off for improving range of motion in this next decade. I'm hoping for it at least. Botox plus hip bracing gets a positive, but I don't do it, and I don't really know people who do it in Connecticut. I could be wrong though, but I haven't recommended it. So we could talk more about the surgeries if you want, but we'll see what kind of questions we get. I'm just going to plug this again. I would definitely just download the table. It has every single thing that is talked about here, and you can see how it's laid out. So it tells you what the outcome was, what the citation actually is, so who the author is in the year, who they studied, what the intervention dose was. So if it's like physical therapy after surgery, it'll say, the dose that the intervention was 2 times a day for 4 days out of the week or whatever. And then the panel's comments are how they rated it and what the grading system was. And then they give you the grade recommendation and the traffic light. And so, you can take this tool into your clinic, just print out the chart. And if parents have questions, what about this? Or I was searching the web and my kid has quadriplegic CP with dystonia. And, there's this like great place in, like Arizona, and they charge, $100,000, and we go there for 2 weeks, and I get to go to a spa and my kid does this. And you could look at it and say, oh, well, it's probably not worth it. It's below the line, or it's green. It's great. Go do it. So I think it's really a great article to catch up and evolve your practice and also confirm the things that you've been doing that are great. So, in summary, we have a lot to learn. There's a lot of yellow on here, and there's not much green or red. And so I think moving those yellow things or being more specific on which patients get those interventions will help push things over that worth it line or not worth it. And then this is a really great time and a great way to inspire you to kind of take a deep dive into your own practice. And like for me, I started with all the reds. I was like, oh man, I better make sure I'm not doing any of these reds. And then with everything I'm doing now, looking at the chart, say like, why am I doing it? So when I recommend, like for one great example, I was taught in my training that you should give all the kids night stretching splints for their equinus contractures. And then when I became an attending, I had the first mom say, he doesn't wear this, or she doesn't wear this, or she takes it off, or she cries when we put it on. I asked, like, why am I doing this? And so now if I look at Dr. Novak's article here, I could clearly see that there's probably not a role for that in practice. So I don't do that anymore. Well, I didn't do it since becoming an attending. Here's a bonus article that we didn't talk about, but I think every CP talk has to include this as sort of a way to view your treatment. This is a different article that is kind of fun to read. And if you're someone who's like a ICF framework person, this is I think a better way to think about it. So these are the F words, the 5 F words in childhood disability. And Peter Rosenbaum and Jan Willem Gorder are both just great folks, great minds in CP and transition thinking and things like that. So this is the International Classification of Functioning, the ICF model, where you have a health condition and then, your intervention and studies kind of fall within this framework. So body structure and function, activity, participation, you see everything is very interrelated. And then with personal environmental factors. So instead of that, I propose that you replace it with the F words. And I think everybody should know these F words, commit them to your regular practice. So fitness, function, friendships, and then family, factors, and fun. And if you think in that perspective, why am I doing something and what am I trying to affect? I think it makes it a lot more palatable and easy to remember that there is a person you are treating and you want to give that person the best life and quality of life and function as possible. So with that, I thank you. And we have some time here to talk about some stuff. It's a pretty dense article, so.
Yeah, you did a great job covering it all, Dr. Fromberg. Thank you so much. We do have a few questions that have been trickling in. The first question comes from Samantha Rockwood. First of all, she says, thank you for doing this presentation. I use this article to guide treatments and answer many parental questions of what are your thoughts on X, Y, and Z. As an MD, what do you want from local PTs that isn't widely available in Connecticut, regardless of COVID?
That is a great question, man. Where do I start? I think the first thing, so I look at PTs for kids with CP as like their primary care provider. It's not a pediatrician, obviously, but if you think about it, like who sees a kid more than their therapist? So I think everybody is sort of doing the right stuff, really function-based treatments. But most importantly, I think that PTs need to remember that they're the first line to discover when things are contracting more, when spasticity is increasing or is not well treated. And honestly, like my 10-minute visits with parents, it's really hard to talk to somebody about like a selective dorsal rhizotomy. I wouldn't want a PT to have the onus of doing that, but something like, if like I'm talking about calf surgery or something, like your equinus contracture and it's getting in the way, let's say someone has hemiplegic CP and they are trying to round the bases when they play baseball and they just are tripping up because they're tripping on their toe because they have an equinus contracture. It's always odd if I'm the first person to point it out. Usually PTs recognize that and sort of raise the red flag. And I think that helps parents understand why they're going to PT and sort of keeps track of them. So I think that the most important thing a PT can do is sort of be the primary provider for that child. And it's what I respect the most about PT. That goes for OT also, by the way. I don't know if that answers the question.
And then another question that we have here is, when you're doing hip replacements for these patients, what is typically your criteria, and what's the youngest that you'll do a hip replacement?
Good questions. The biggest problem is that the evidence for hip arthroplasty is not perfect. And so let's say, for example, you're doing it for arthritis, just because you have cerebral palsy doesn't mean you might not also develop arthritis in your hip joint. So if you're someone who is, GMFCS 1, 2, 3 kind of ambulatory person, then I usually don't do those hip replacements. I have fantastic joint replacement partners that do those. They like to do those. They're very good at them. And so as long as their tone is under control, they don't have any other deformity or contracture, I generally pass those off to the hip replacement doctors, and that could be any age. Obviously over like 16 or whatever, but it would be rare for those people to need it at a very young age. Now, as GMFCS increases, your risk for hip dislocation increases, and therefore your risk of symptomatic contracture or hip pain or something like that also increases. So, a great example is GMFCS 5 spastic quadriplegic girl who is 18, maybe 19, who had 2 attempts at reconstruction of her hip that were not successful, and she had really an end stage hip that looked kind of like a cube, and you can't fit a square peg in a round hole. So, she got a hip replacement. It's not your typical hip replacement. Years ago, like now, if you're in a different spot, those people generally get something called a proximal femur resection, where you literally just cut off the ball of the hip, and you get a little bit of pain control and positioning improvement, but it goes away very quickly, and then you end up just kind of like chasing your tail. So, for me, I think anyone with a hip that is kind of in the ballpark, not a super high and outside dislocation, and really any GMFCS can benefit from a hip replacement if it's possible, as opposed to proximal femur resection. There are some people who get through their childhood and then in early adolescence, they maybe had like a lot of the things that I find in my adult practice are adults who had maybe a little bit of hip dysplasia. It wasn't enough to prompt somebody to do like a femoral osteotomy or something like that. And then as they grow up, their hip was always just a little bit abnormal, and then it wore down a little bit differently. So I think I am seeing some people who benefit from hip replacement at a younger age, and I think it's becoming more and more accepted. I mean, we just published a paper showing that the outcomes are pretty much identical if done, for ambulatory folks. So there's a lot of papers that show hip replacements last just as long. But I think, tone management is super important too, because the dislocation risk is higher.
And then the last question we have is, what is your advice to physical therapists on educating patients about pain, especially since a lot of the pain interventions are not shown to be extremely effective?
Yeah, that's a really hard question. Literally today, I struggle with this. I saw a kid who's 26 years old. I'm trying to go back to my pain thing. I think this is it. So 26-year-old I saw today who has a ton of pain in his hips. I mean, they're a little bit dysplastic, nothing crazy. And so what do we do, right? I mean, I find at times I'm just grasping because they'll come to you. Probably what happens is they come to me or they come to somebody and they say, you're just tightening up, go see a physical therapist. And then they end up in a PT office and you're like, what am I going to tell this guy? So, unfortunately, pain seems to be part of the natural process. There's a lot of evidence that is not presented here that like mindfulness and all the multimodal things that you can do to treat pain all help. If you talk to adults with CP, some of them that are in our community group from the Academy of CP and Developmental Medicine, they'll tell you that there's not one silver bullet. So, taking gabapentin is not going to help on its own. Taking Motrin is not going to help on its own, but doing all these things together seem to help. Mindfulness, aromatherapy, like literally anything. I mean, I would tell them as a PT that it is a very difficult problem, that we don't know the source of it. It doesn't necessarily come from the brain. It doesn't come from the muscles themselves. It could be soreness of the muscles. It could be contracture altogether. It could be years and years of asymmetry across joints. There's so many different things that contribute to pain, and there's not one solution for it. So, as a PT, it's in your nature, you want to be empowering. It's just very tricky with pain because there's not one specific thing you can do. I think trying to get people to, so figuring out how the pain is interfering with their quality of life specifically, and then maybe trying to get around some of the barriers, like if it's painful to put on shoes because their hips are killing them when they bend over, then maybe coming up with alternatives for that. That's just one possible example. But there's really not a good answer for treating pain, and so there really isn't a good answer for how you can advise a patient, other than to say we don't really know in 2020 what causes it, and it seems like everybody gets pain that's very difficult to manage. Remember that a lot of these adults and young adults, when they were kids, were probably told by by their parents that they, or overheard their parents say something like, he or she has a really high pain tolerance. That's something that we hear a lot. And I don't necessarily believe it's true, but especially people who have communication barriers you may be told that they have high pain tolerance, but it's probably not true. So we do think that there is a high incidence and prevalence of pain in the population. I don't have an answer for you tonight, unfortunately, and hopefully that's like the number one research thing that we can get by the next publishing of this chart.
Wonderful. Well, I just went through all the questions. If anybody else has any last minute questions, if they would like to unmute their microphone and ask Dr. Frumberg at this time, feel free to do that. I'll give you a couple seconds here. Doesn't seem like it. Well, thank you guys for joining us again this week. And thank you, Dr. Frumberg, for taking time out of your busy schedule to educate us on this article. It's been very informative. I think we've all have learned a lot. We'll be doing another journal club again next week. So same time, 7 o'clock. If you are wanting to sign up for our journal club, just go on to ctpt.org and put your name and email in the box, and we'll send you the invitation and the link. And thank you, everyone, for joining us once again.
Thanks, guys. Be safe.